Hello friends from Great Lakes Seminars. It is my opportunity to share a couple techniques with you that I really like. So we're going to be talking about transverse plane motion at the knee. Typically people think about the knee and think of it just being a sagittal plane where it extends, it flexes, and that's true. That's a really big component of that. But what I really like more than anything for the knee is that rotation aspect of it. When you're not getting good rotation of the knee, you're getting stress on the meniscus, both medial and lateral. If the knee's not going right, you're getting issues at the ankle. You're getting issues at the hip. Eventually, the ground reaction forces are going to come up and start pounding on your low lumbar spine. So this is a big driver for low back pain as well. So there are two different techniques that I like to do from an MFR standpoint to work on improving the rotation mechanics of the tibia on the femur. One is the short head of the bicep femoris, and the other is popliteus. So the short head of bicep femoris, what it does in an open chain is it gets an external rotation of the tibia on the femur. Popliteus is the opposite. It is an internal rotator of the tibia on the femur. So what normally happens when you extend the knee, to get terminal knee extension, you need a little bit of external rotation of the tibia on the femur. So it's the short head of bicep femoris that does that. If it's not doing its job, you may not quite be getting terminal knee extension. And then once you do get terminal knee extension, it requires an unlocking of that screw home mechanism, which is an internal rotation, and it's popliteus that does that. So it gives the internal rotation to allow the knee to flex. I'm going to show you a myofascial release approach to improve the rotation of the knee. So the first muscle we're going to do is popliteus. That is an internal rotator of the knee in open chain. It runs from the posterior medial tibia to the lateral femoral condyle. So it is running at this angle at the posterior knee. It's the deepest thing at the back of the knee, so it's deep to everything else when we're getting there. So to find this one, you find the spot where the gastrocnemius heads split right there, and right in that point we're going to sink in to feel that muscle. It's the only thing running obliquely there, so once you get down there deep enough, you'll feel that muscle running right at that angle. Sometimes it helps with this to put it on a little bit of knee bend. That puts some slack in there and you can sink in there a little bit better. So when we find a hot, hard, tender spot, just some people call them like a trigger point or just a knot. When you find one of those, the MFR approach to it is we're going to sink into it until we get a little bit of pushback from the tissue. We're not pushing all the way down to the tibia, but just to the point where it starts to push back at you. We're going to maintain that depth. And then we're going to wind it up a little bit. So I'm going to see what's tighter, going toward the tibia or toward the femur. It's tighter going to the tibia, so I'm going to hold that. Then I'm going to immediately go perpendicular to that. Which one's tighter, down or up? It's tighter going up, so I'm holding it toward the tibia, I'm holding it up, and then I'm going to add a little bit of rotation to it, and clockwise is tighter there. So once we get all three of those wound up, the clock starts. And for a release to occur fascially, it usually takes about 90 to 120 seconds. So we'll just wait for it. Hey, look, it just went. Wow, it went faster this time. That's amazing. Wow, it must be that camera. It just speeds stuff up. So that is the popliteus approach. Its friend is short head of bicep femoris. So the landmarks for finding the short head of bicep femoris is the long head for the bicep femoris. That one comes right down and attaches here to the fibula. So that muscle is right here. If you're having trouble finding it, you can just have them bend the knee a little bit. Go ahead, bend just a little bit, and that one will jump right out at you right there. Okay, so that's where the long head is. And then the other landmark is the IT band. So in this area right between my fingers right here is where the short head of the bicep femoris is. The short head of bicep femoris is an external rotator of the tibia on the femur in open chain. So we are going to look for right in that little triangle. Oh, wow. How's that feel? Uh-huh. Yeah, there's a good spot right here. So what we're going to do is the myofascial release approach again. So sink into it, and we're going to see what's tighter, going up or down. It's tighter going down, so I'll hold that. Then we'll check perpendicular. It's tighter going this way, so I'll hold that. And then I'll do a rotation right there. Okay, I can use my thumb like this. I can use a couple fingers coming at it like this. A little small for my elbow, but that's the idea. So just like with the popliteus, we hold it 90 to 120 seconds, and we wait for the release to occur. So what patients are we going to want to check this on? Well, there's a few different knee diagnoses that make me think immediately go to the transverse plane. The first is any type of patellofemoral issue at all. If you've got a rotation there, that patella isn't going to track right and is going to cause a lot of trouble. Another is any type of meniscus problem that's going on. If you've got altered rotation at the knee, those meniscuses are going to get beat up. So if ever you have meniscus issue, you should also look at these. People who have chronic osteoarthritis of the knee, one of the causes of that might be that they, for decades, haven't been rotating correctly at the knee, which has led to arthritis, and you might not even see them until after their total knee. But these are something that I'll do for the total knee patients as well. Realistically, any knee diagnosis that comes your way, at least screen these, at least check them, because not many therapists look at them, and they are definitely a cause of a lot of mischief and problems at the knee.